Welcome everyone to Alan Hu Foundation Mental Health Lecture Series. I'm Chi-Ching Hu, co-founder of Alan Hu Foundation and host for your webinar. Today, Dr. Glenn Saxe will present helping traumatized children and their families with trauma systems therapy. We'd like to thank TST Values Community Foundation for funding this webinar. We'd also like to thank Mental Health Association for Chinese Communities for providing simultaneous Chinese interpretation. Thank you to Ida Shaw for Chinese interpretation, and also thank you to Ophelia Correa for Spanish interpretation. Alan Hu Foundation's mission is to promote mental health, raise awareness, and remove stigma surrounding psychiatric disorders, and support fundamental research for cures. Please consider making a gift to Alan Hu Foundation by using the donation link in the chat box. Thank you for supporting our programs. Today, it is our great honor and privilege to introduce Dr. Glenn Saxe. Dr. Saxe is a professor in Department of Child and Adolescent Psychiatry at NYU Grossman University School of Medicine, an investigator within NYU Langone Health Neuroscience Institute. Dr. Saxe is also director of the Center for Child Welfare Practice Innovation, a national child traumatic stress network. His research has focused on determining factors that contribute to children's risk for adverse outcomes following trauma and targeting factors using advanced computational data methods to lessen risk. Many children experience traumatic events like injuries, disasters, war, assaults, and mistreatment both in the United States and around the world. These devastating experiences can put children at risk for serious mental health issues throughout their lives, including post-traumatic stress disorder, depression, substance abuse, and even violent or self-destructive behaviors. In today's talk, Dr. Saxe will provide a perspective on how trauma affects children and their families, sharing an approach that has helped countless people. Trauma systems therapy is an intervention method designed for traumatized children and their families. TST focuses on helping children develop greater control over their emotions and behaviors when faced with these reminders, and guides families on how to support children in building resilience. Additionally, TST addresses situations where children encounter real threats. This webinar is being recorded. The recording will be available on the Alan Hu Foundation website and Alan Hu Foundation YouTube channel in about 2 weeks. Please subscribe to Alan Hu Foundation YouTube channel. And following the presentation, there will be a Q&A session. Please use the Zoom Q&A function to submit your questions. The presentation is for educational purposes only, and it is not intended for medical diagnosis. If you have any persistent symptoms, please seek professional help. With that, I'm turning to Dr. Saxe. Welcome, Dr. Saxe.
Well, thank you very much. And it's quite an honor to be invited to speak to you and your foundation and your people here. Let me just share my screen and get my slides set up. Okay.
Yeah, it's good. I can see it.
You can see it?
Yes,
okay.
Good. Thank you.
Okay. So I always start when I give a talk like this to talk about the values of trauma systems therapy, because that really is our anchor. And in our book, we talked about the imperative to never look away. We cannot look away. We are called to act, to engage, to remember, to help, and to share the pain. And people who practice trauma systems therapy take this very seriously, and it's easy to look away from the needs of a traumatized child. And part of the reason people can look away is because trauma is so devastating, and it's hard to see the suffering that happens. This was a study published almost 10 years ago that looked worldwide. This is in the journal Pediatrics, and found that 1 billion kids were exposed to violence worldwide in the past year. And if you look in the United States at the child population that are subject to child abuse investigations, it's a lot of kids. And if you look at kids in the United States, even in the foster care system, 5.8 of 1,000 children, that's just a lot. And so this all shows how common trauma is. There are several types of events. This is maltreatment, physical abuse, sexual abuse, neglect, all kinds of sources of trauma. There's injuries, disasters, burns, war, um, terrorism, child removal from home, neglect, poverty, many, many sources of trauma. So let's define what we mean by trauma. So an event is traumatic where it threatens physical survival of a person or someone close to them, or it threatens one's core sense of self. So a threat to physical survival is not hard to see. But what do I mean by one's core sense of self? And what that means is something happens in your sense of who am I may change forever. And this happens in assaults, sexual assaults. It really affects my sense of identity. And that's very important to grapple with. Now, one thing to know is that not all individuals exposed to trauma develop a bad psychiatric response like post-traumatic stress disorder. In fact, only 15 to 40%, depending on how you count, will develop a bad psychiatric traumatic stress response. So the good news is that people are resilient. You know, we've our biology has been created and our social networks have been created to really support resiliency. But the bad news is that if you look at the numbers of people who've experienced trauma, 15 to 40% is an awful lot of people. So if a bad effect happens as a result of trauma, what are the type of effects? So there are significant psychiatric problems, traumatic stress responses, which I'll talk about a lot later, depression, aggression, self-destructive behaviors, substance abuse, many, even more different types of problems. And then there are all kinds of functional implications affecting school performance, social relations, as kids grow older, employment, homelessness. And so this is a very, very, very big problem that we need to grapple with. And in grappling with this, as a psychiatrist, and I think about putting people in certain categories of what's called psychopathology, I always remind myself about reality. And what I mean by that is this. Before we put a kid into a category that they need treatment for some disorder that they may have, we need to ask ourselves, have we properly stood for reality? And that means, have we properly stood with the child? So I'll give you examples of what I mean about problems that we ought not to put just in categories of psychopathology. The child who does not want to go to sleep at night because he or she's afraid of being abused in the night hours. Child who lives in a neighborhood where there's a gang war and spends a lot of time scanning the environment for sources of threat. the child who avoids going to school because someone has threatened to kill her, the teen who's aggressive with his mother's boyfriend to protect her from getting beaten up. You know, again, this is reality for many children. And if we put it into a category of a psychiatric problem, we really miss the need to protect kids. And so the most important rule here is to never treat a child for a problem that reflects the craziness or evil all around them. A child needs protection in these contexts, not treatment for their problem. So let's now talk about trauma systems therapy. This is a treatment that I developed with my team. This was in, the late 1990s, 2000s. And why did we develop a new treatment? We developed it because it wasn't just a kid's reaction. It wasn't a post-traumatic world. Kids were exposed to ongoing events, ongoing threats, ongoing traumas. And if we just treated it as post-traumatic, we would be missing something awfully important. And so TST has developed over this time to really be refined to address the realities of kids' lives. So why TST? As I've just said, well, kids don't live in post-traumatic worlds sometimes. Kids and their families are complex, and we have to really grapple with the complexity, as I'll be talking about. It's hard to make treatment work in the real world, and so TST is really designed for organizations, for how workflows in the real world clinics to be feasible, practical. It's as much an organizational model as it is a clinical model. And because we could never look away. And so again, this is the bedrock value of TST. And I could talk about what it means to look away and what it doesn't mean to look away. And we'll actually talk a lot more about that. So we wrote this. This was our second book. And we wrote this about 10 years ago. And it really describes a lot of detail about this. And usually I present for clinicians and other providers to care for traumatized children and their families. And I realize most people in the virtual room here in the audience are not clinicians or providers, family members, teens, people who are, again, not mental health professionals. And so, I'm going to try and make TST as tangible for you as possible, and also be talking about, how we train the people who look after kids in order to help them. So, why do traumatized children typically present to care? Usually, not always, but usually it's because they repeatedly express episodes of uncontrolled emotion or behavior that either the child or someone else sees as problematic, like a parent or a teacher, and wants the child to be seen for help because of these repetitive episodes. So, because this is the main problem that presents to clinicians like me, we designed TST for this. So, to make this discussion as tangible as possible, I'll tell you about 4 kids with trauma presenting for care. Brianna is a 15-year-old girl who repeatedly cuts her arms and says she wants to die. Marcus is a 17-year-old boy who has had multiple episodes of running away from his foster home, missing school, returns home intoxicated. He's at risk for losing his foster care placement and repeating the year at school. Leah is a 12-year-old girl who at times seems in her own world, fully disengaged from what's going on around her at home and at school. And Eddy is an 8-year-old boy with repeated episodes of hitting, kicking, biting other kids and adults. Most recently, he ran at his teacher at school, knocking her off her stool. So, as you could see, each of these kids have very serious problems. We need to think about how to help them. How do we help them? So, when we train clinicians, we train them to think of these episodes as mysteries that need to be solved for clinical care to be successful. What are these mysteries? We need to look for clues. We need to solve them. We need to be deeply, 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 deeply curious about what's going on inside of a child so we could understand why they express these episodes of emotion and behavior. So, what are mysteries? Here are the 4 mysteries. Why does Brianna cut her arms and say that she wants to die? We have to be curious about that. Why does Marcus run away from his foster home, his school, return home intoxicated? Why does Leah seem in her own world and is completely disengaged from everything going on around her? And why does Eddy kick and bite other kids and adults? So, whether you practice TSC or not, these are the kids that present for help. And to provide that help, we have to solve their mysteries. Otherwise, we don't really know what to do. So, I presented this slide to clinicians. So if they come to care, how would the clinician go about solving this mystery? So you may ask yourself, what does it mean to solve a mystery? Here's what it means. If you solve a mystery, you could predict when these episodes will happen in the future. They'll happen in the future because you understand the conditions by which the problems will occur. And if you're able to predict it by knowing the conditions by which these episodes occur, then you're in the position to intervene to prevent the expression of these episodes because you understand the conditions controlling their expression. Now, in my field, here's a confession for everyone. We love explanations. We could explain anything. You can get these long stories that sound, because they come from people like me, like we know what we're talking about. But the only explanation that is true is the one that predicts what's going to happen in the future. And that's where expertise comes in. And so if you're able to predict it, you know what you're talking about. And so we gather data to be able to make these predictions. And then we think about, well, what sort of data that we might know about a child or family will help? Might it be their diagnosis? Might it be elements of the trauma history? Might it be something about the family history, including family members' trauma history, their culture, experience of mental health, their child welfare systems? What about clinical data on the episodes of the emotional and behavioral expression? So that's what I want you to think about. Like, And I care about anything here as long as it helps me predict what's going to happen. And I'm going to tell you some things are more helpful than others. So what's extremely important and often way overlooked in my field by clinicians in mental health is the context. What's going on around the child that precipitates these events. So if I know these contextual conditions, I could reduce the child's likelihood of having these episodes by decreasing their exposure to the contextual conditions. And I could increase the child's ability to tolerate those conditions so they don't express what seems to be out of control emotion and behavior. Now, then there is diagnosis. And as you may have gathered from everything I've said so far, I'm not so big on diagnosis. I mean, I would be bigger on diagnosis if it helped me predict more, but it doesn't. Why? Because it leaves out the contextual conditions. So we all think about post-traumatic stress disorder, PTSD, and here I'll just go through, the definition. You have a traumatic event, as I've defined already, for which you have intrusive symptoms. You're literally haunted by the event. You see it happening, those flashbacks, you feel it in your body, it intrudes when you're not expecting it. Or you avoid people, places, and things that remind you. Or you have what's called negative alterations in cognition and mood, so that you may not feel emotion normally, or your sense of yourself and the future is all negative, or alterations in arousal reactivity. You can't sleep, you can't sit still, you startle. Now, these are all important. These are all part of the experience of traumatic stress, but it says nothing about the conditions by which these events occur. And that's the make it or break it thing. So it's a useful description, just incomplete. We need to know the process by which an individual shifts to dysregulation, and we have to understand the social context contributing to this shift. And when we know that, we have specific information that's actionable enough. We know what to do. And importantly, other problems that may appear to represent different psychiatric disorders may be part of the same problem. So when we see this, you can get a kit with the same problem that might be disruptive in one situation and in their own world in another. It all depends on understanding the context and process. So a little bit more about context, and I'll talk about it in a very weird way. Ready? So Jaak Panksepp, a brilliant and out there neuroscientist, studied rats at play. Panksepp's, the father of the field called affective neuroscience, emotion in the brain. And he believed play is the basic substrate of the emotion of joy. That's very important evolutionarily for mammals. He says just about all young mammals play. So we know this is very, very important. Okay, where am I going with this? So he studies and quantifies rats at play, and this is a 10-day trial, and he measures play for 4 days, and then he introduces what he calls a minimal fear stimulus, a single hair from a cat. He takes that hair, He drops it into the cage on the fourth day and play stops. And then on the fifth day, he takes the hair out, and life is never the same again for these rats. So why is this important, and why does it tell us something about the human context? Because the kids we're talking about often tragically are living in cages full of cat hair, and sometimes they're living with the cat. And with this reality, we have to address the cat hair to help them. We have to understand the contextual stimulus leading to this. And that's really what it's all about. So now, with that knowledge, let's talk about one of the four kids, Eddy. Remember, he's the 8-year-old boy, repetitive episodes, hitting, kicking, biting other children and adults. Most recently ran at his teacher, knocking her off her stool. How do you think the school feels about Eddy? Often they're not so welcoming of Eddy, given how aggressive he could be and how it seems to be out of the blue, no rhyme or reason, unpredictable. So if we can help predict it, we can do something. We can help people see it's not so random and we might be able to do something about it. So he has a history of physical abuse from his father, was brought to the assessment by his mother for concerns about episodes of pushing his teacher off the stool, kicking his soccer coach, biting another kid at recess at school. Again, it seems these are totally different contexts, and it seemed as random, so we don't know what we can do to help. So even if you look at the record and the psychology evaluation, it writes, Eddy lashes out whenever he feels rejected by someone he wants to please, perhaps related to profound feelings of rejection from father. Eddy's mother agrees with this report, adding, he's so desperate for his dad to want to play with him or even like him. When the clinician conducted this assessment and asked Eddy about his opinion on his mother's thoughts, Eddy shrugged his shoulders in silence. So this raises a very important issue about the assumptions that adults may make about what's going on based on their own ideas, biases, whatever, without really getting at it from the child's point of view and perspective. And TST were very, very, very big on making no assumptions, but gathering data to actually know what it is. Because if let's say this report is true, you would predict, when there's some rejection in this way, that this would happen again. But if it's not true, then Eddy won't lose it when this happens. So we have to be very careful. Okay. So what information we might need? So let me just tell you a few things to help. So we define traumatic stress in the following way. It occurs when a child is unable to regulate their emotional states and in certain moments experiences their current environment as extremely threatening, even when it's relatively safe. We talk about survival state expression, which is a characteristic pattern of maladaptive thoughts, emotions, behaviors expressed by a traumatized child, resulting from the child's perception of threat in specific context when the child is not under actual threat. And then we put this together when we look at different episodes and we see how they may be connected, even though they don't look connected overtly. It's a predictable pattern of a traumatized child's survival state expression in response to particular contextual stimuli on occasions when the child is not under objective threat. So we need to know a lot about these episodes to be able to see if there's a pattern and make no assumptions. So let's talk about what was gathered. So the first episode that you know about, Eddy ran at his teacher, pushing her off her stool, immediately following his teacher handing him his spelling test that was graded unsatisfactory, while she commented with a critical tone of voice, "Eddy, you're just not making the effort I expect in this class." Second episode, Eddy impulsively kicked his soccer coach after his coach placed another child, Jerry, in Eddy's position on the soccer field, explaining to Eddy because Jerry tries harder than you in practice. Third episode, Eddy bit another child at recess during a competition between several kids on the monkey bars on the playground, a task that was very difficult for Eddy. The other kid laughed at Eddy and loudly explained to the other kids, "See, Eddy can't do it no matter how hard he tries." So, do you see a pattern here? That's what we're looking for, because if we see the pattern, then it's predictable. And so, this is part of a form that we have to look at and examine it after we collect this data. So I'm just going to tell you what we found. I expect many of you will be anticipating what I'll be revealing here. Child Eddy repeatedly expresses episodes of hitting, kicking, biting adults or peers when it's exposed to criticism of his effort when he is trying his best. And then we look at, this is what we call trauma inference, where this might come from. And Eddy experienced physical abuse from his father when his father believed Eddy was not trying hard enough. So, in a way, Eddy's father was trying to teach him, you have to be like a man, you have to try, and would then beat him when he wasn't trying hard enough. And you can imagine then what this sets up. So then what we need to do is, with this knowledge, that's all we focus on, because there's no way we're going to be able to get a handle on helping Eddy until we can help reduce the amount of time he's signaled in this way. And then ultimately, we have to get Eddy to be able to regulate his emotion, because within the bounds of reality, he's going to get communication that he hasn't tried hard enough, and he's going to need to be able to manage it without losing control and getting really aggressive. So both of these things define the intervention approach in TST. Okay. And so this is another form which is part of the intervention strategy, and I'll just reveal this. Child's exposure to criticism of his effort when he's trying his best will be decreased by asking his parents, teachers, soccer coach, school monitors to proactively praise Eddy when they notice his effort. You know, they didn't know this was such vulnerability, so they should be bending over backwards, never to make him feel insecure about his effort, and certainly never criticize him for his effort. You don't do this for every kid, but you always find out what makes them most vulnerable. And that's where everything goes, to support them. And then it's not only protecting Eddy from the environment in this way. As I said, you have to build his skills. So we help him build emotional regulation skills around any signal about his effort. And in this regard, sometimes we'll integrate pharmacology to help him manage emotion a little bit better while we're trying to build his skills. I'm not saying in every case we do this, we have to really see, but the goal is to always get, you don't need pharmacology when you have the emotional regulation skills. So there's a few more things to know about TST. It's always about a trauma system. We never intervene only with the child. It's always the child in their social environment with whoever is there to support the child. And also when we recognize that people need to change their behavior because they keep stimulating the child in this way. So a trauma system, that's why we call it trauma systems therapy, is defined in these two ways. A traumatized child who expresses survival states in specific definable moments, and they live within a social environment or system of care that's not sufficiently able to help them regulate these states. It's never about the child alone. It's always about the child and those around them. And that's necessary in TSC. Oops. We work with agencies, organizations, and teams. This work is done in a multidisciplinary team that needs to be working together to figure out how the mysteries to be solved. And you need people to be, you need teams to figure this out. And then we engage with children and families in very, very specific ways. We intervene, and then we appraise whether it's working. And how do we appraise? Primarily by prediction. In other words, if we think we get the problem and we intervene in the way we think it'll work, we're predicting it's going to get better. There's going to be less episodes, and they're not going to be as, worrisome through our treatment. But let's say it's a month or 2 months and it's not changing, then that's always telling us we've missed something. And then we go back and see what we've missed. So we're always working it and working it, and we always do this from the perspective of humility, that this is hard to get, it's easy to be wrong, and we're always checking and rechecking. TST has 3 phases. Kids and families start usually in either safety focused or regulation focused. Safety focused is when the dysregulation means risky behavior, like a kid is harming themselves or others. Or the other part of safety focused is when there's a clear and present danger to the child. It's not just CAD hair, that there is real present risk, and safety focused treatment guides the care around that real risk for the child's protection. Regulation focused treatment is when the environment is safe enough and it's really focused on building the emotional regulation skills and building the skills of caregivers to support the child. And beyond trauma is helping the child and family see themselves beyond being a trauma victim and moving into a healthy, successful future. We also here do trauma processing. Most people may think all of trauma care is trauma processing, where you have to go over and over that trauma. We only do it here because if you do it and the environment isn't safe enough, that's very problematic. You're treating a trauma as if it was in the past when it's actually in the present, and that's harmful. And if you do trauma processing when the child doesn't have enough emotional regulation skills, you'll make things worse because then they'll start cutting themselves again or getting violent, all of that. So they need to have enough emotional regulation skills. And so this just summarizes what I've just said. And we use the multidisciplinary team has four um, elements. We have skill-based psychotherapy, home and community-based services, pharmacology when we need it, and sometimes we'll have legal advocacy because in safety focused, we often will have to advocate with the family courts or the child protection agency. So having a lawyer that helps us do that could be very useful. It has a very specific engagement approach because, you can have the most brilliant plan, but unless families and children are engaged in what they need to do to move forward, nothing's going to work. We think about engagement a lot. Um, Again, it's conducted within a multidisciplinary team that's supported by their agency in this really, really difficult work. And we've, over the years, disseminated it. Right now, we're in 18 states. In 4 nations, it's been adapted widely for all these different services or trauma types and all of that. Um, and I think that's just about everything I wanted to say. If you want to know more or get TST, where you're located, just here's a QR code. We also have something called the Never Look Away Trauma Training Program, which is it's TST is for training clinical teams to do this work. Never Look Away it's not about training teams to do it, but it's training providers. We have programs for parents, for foster parents in basic trauma, understandings of trauma and trauma-informed care based on TST principles and practices. And so we're really interested in hearing from you if you're interested in this. And I think that's everything I had to say, and I'm looking forward to the discussion.
Thank you, Dr. Saxe, for the wonderful presentation, introducing the trauma system therapy to us, and also teaching us about the nice concept about finding the mystery first. Now we're open up to Q&A. The first question is, we are implementing restorative practices as a school, and it is often children or families that are struggling with different types of trauma that get caught up in punitive systems. How do you suggest supporting those students that may have undisclosed traumas, especially if they are hesitant to share with the school community?
Yeah. Well, I think I gave kind of a perfect example of that, Eddy in the school. So, how do you think the school reacts punitively when they completely don't understand why Eddy knocks the teacher off the stool, why Eddy kicks a soccer coach or bites another kid? If it's unexplainable, if they don't have any explanation, everything goes into controlling the kid and punishing them, setting consequences like this that will not help because they don't address the problem. So, to help kids like this, we have to understand them. Now, that means really being curious about what's going on inside of them, not making assumptions about what it must be based on our own biases or that sort of thing. Certainly, if problems are elevated to a certain level, getting a mental health clinician to evaluate this. But I think too, I think a basic principle I'm trying to communicate is since kids are complex, just because, and humans are complex, we're all complex. Just because we've had a trauma experience doesn't mean that explains our response. It really must be understood at the right level of detail, which is what I was trying to show.
Okay. Next question. Will trauma system therapy help bipolar patients with low cognition who refuse to take medications and treatments and have bad be and had several suicidal tries and involuntary hospitalization?
Yeah. So, I was trying to say this before that sometimes you can have all these diagnoses. You know, you can quote the Saxe principle, which I've never published, but I repeat in many lectures to mental health professionals, including psychiatrists. If you have three or more diagnoses, it means you don't really know what's going on. And what I mean by that is, sometimes a traumatic stress response, as I've said, will be diagnosed with bipolar disorder. Uh, a person may seem really driven, but they're not driven always. They're driven in certain contexts, or they may, get destructive or really sad, but it's not always. It's in certain contexts, like I'm saying. So it really is an issue of what we call differential diagnosis versus comorbidity. Differential diagnosis means, you know, we think it's this bipolar disorder, PTSD, depression, whatever, borderline personality, but it's really the process I'm talking about. Comorbidity means, okay, people with genetic predispositions to bipolar disorder who have that psychopathology can also get traumatized and have traumatic stress reactions. So you have both. So an expert mental health clinician must sort that out. And if it's really the process we're talking about, it has to be treated in the way I'm talking about.
Right. Considering the high number of people suffering from trauma-induced mental health illnesses, um, why is there not more trauma-informed trauma treatment available?
Yeah, I mean, I guess there are many treatments available, um, but the question is where they might be available. I'm part of the National Child Traumatic Stress Network, which is really spread. I mean, it's the United States, not the world, but trying to and it's in, most states at one have had either have or have had an NCTSN network center, which it becomes a hub for trauma-informed care. It should be, given the prevalence, as the question says, I wish these treatments were more available. I think some of it has to do with funding, that sort of thing. But it should, I think that's a political thing to really advocate wherever you might see it not being as available.
Hmm, okay. So next question. If diagnosis leaves out context, what exactly is it based on? Symptoms, thoughts, or moods?
Yeah, I mean, basically, I've like many problems with psychiatric diagnoses, but it's based on what are called mental health symptoms, which are essentially expressions of emotion, behavior, or thought, certain patterns that fit together that seem to be some sort of syndrome. One of the things with mental health diagnoses, unlike every other medical diagnosis, is it was decided in 1980 that that diagnosis would be without regard for causation. So these are symptoms expressed from the brain and their effects of that, but without the ability to know what the cause of them are, it leads to all kinds of trouble with intervention. It's like you pick any diagnosis, say depression, bipolar disorder, what the for every, we think there are many causes for each of them. But if we treat everyone in the many, 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 many people in that category the same way, but it's multi-causal, we're going to miss huge things. Now, I could spend 3 days talking about this in the other part of my life with I apply algorithms and methods to infer causes and that sort of thing. It's very important to me, but that's a key problem with psychiatric diagnosis.
Mhm. Right. Um, Next question. For my loved one, his mood and emotional state seems to come and go every so many weeks or months. Is there a temporal component or triggering event that we do not recognize?
Yeah.
Um, yeah.
So, it one of the key distinctions, I think, in mental health is whether the state of emotion or behavior is context dependent or context independent. So you have disorders like bipolar disorder, where it's relatively context independent and it happens for biological reasons. If context is involved, it's not that strong. But then you have problems like I'm talking about that are very context dependent, and you must know. And one of the reasons cat hair is a very important analogy is it's minimal fear stimulus. It's things people wouldn't notice. And that's the space I'm in. It's like no one noticed Eddy's cat hair having to do with, some statement about his effort. Who would have thought? However, with his history, that's going to be very potent. So it's natural that people won't know this unless they're very careful asking. And so I think if you're a family member, just being curious, trying to understand the person's who you love's perspective, maybe noticing certain things, and always, you know, getting a mental health consultation to help figure this out. Because sometimes it's hard to know unless you carefully look.
Okay. The next question, a large number of people with intellectual disabilities and or autism suffer from trauma. Is a TST effective for this population?
Um, yes, we don't have dedicated programs for this, but we've treated over the years many kids with autistic spectrum disorder. And so, if they're less verbal, then we use play, drawing. It's just like we work with very young children as well. So you reach them at the level where they are as far as expression goes.
Okay. Um, we're about time. Two more questions.
Sure.
Okay. Is it possible that a young adult who experienced trauma as a child did not have behavior challenges during childhood, but developed major difficulties during late teen and the young adult years? How do we use the TST to solve the mystery and help such a young adult?
Yeah. So part of it is, again, let's start with not making any assumptions. So Trauma may have nothing to do with the problem. Trauma may have everything to do with the problem. And you determine that by doing an assessment such as I modeled for you with Eddy. So if they're the episodes this person who's a young adult has, you want to know what's going on, what happened. If there's likely several episodes, many episodes, they may seem very different in very different contexts, but there may be a similar underlying thing that may be very much related to the trauma. And so that's what needs to be assessed. Again, it may not, but it may, but the only way you'll know is to gather the facts.
Okay. And the last question, for years, LGBTQ youth has been invalidated and has been told that they were bad and needed to be corrected. Does that experience count as a trauma? If so, can it cause anxiety disorder, major depressive disorder, bipolar disorder, or suicide ideology? Can TST help such a youth? How does it help?
Yeah. So, without getting into its cause of different disorders, which I've already said
Hmm.
I'm not so big on, but let's just say causing certain emotional reactions presently. So then it's assessed in exactly the same way I've just talked about. What are the emotional reactions or behavioral reactions that are problematic today? Let's look at each of them and let's see if we could see a pattern. And if that pattern appears to be related to the invalidation, then we have our answer. And then our treatment is all about being invalidated in that way. However, just like I've said about everything, we can never presume that that's true without gathering the facts.
Right, right. Okay, we're about time. Thank you, Dr. Sachs, for sharing your knowledge about trauma system therapy with us today.
Well,
Thank you so
thanks for your
much.
attention. My pleasure. Thanks, everyone.
Thank you. And thank you to everyone for joining our webinar. And we hope to see you again in the next webinar. This webinar is being recorded. Recordings will be available on the Alan Hu Foundation website and the Alan Hu Foundation YouTube channel in about 2 weeks. And please subscribe to Alan Hu Foundation YouTube channel. And also, please take a moment to fill out a short survey. Your input is critical for us to improve our program. I will leave the donation QR code for a few more minutes, and thank you for donating to support our programs. With that, I'm closing this webinar. Thank you, Dr. Sachs.
Thanks, everyone. Thank you.
Thank you. And thanks, everyone. Take care and stay well.